Hello, everyone. Good morning, good evening. It's always my pleasure to share knowledge and experience with dear doctors and friends from all over the world. Today, we will talk about diode lasers, especially in diode laser assisted peri-implantitis treatment two-case discussion. Before starting my lecture, I will share with you a case to show the power of lasers, especially low-level laser therapy or photobiomodulation. This case is feet which has a venous ulcer. The patient have congestive heart failure, and his heart is working around 45% only. This causes poor venous return to the heart, and that causes venous ulcer. I've decided to treat this patient with low-level laser therapy. After just one visit in 3 days, it looks like this. If we notice here, the whitish color disappeared. We now can see red color. The blood is going back to the feet, and this is how it looks after 1 month, and after 2.5 months, I have complete healing. As a periodontist and as implantologist, we may face many cases like this in our clinics. If you face such a case, like the one on the right or on the left, what do you think? Treat this implant or to extract this implant? From the first look, my decision always to extract such implants. But today we will think more than twice. We will have short introductions about lasers. Laser mean light amplification stimulated by emission of radiation. Then laser is light or light energy. What's the difference between ordinary light and laser? First, laser is monochromatic, one color, but the ordinary light is the mixture of the rainbow color. Laser is collimated, concentrated to one point, but the ordinary light goes in every direction. The wavelength of the laser is coherent, well-organized waves, but the ordinary light, it's not well-organized waves. How can we have a laser? The laser device is about a box with one mirror and another partially transparent mirror, and the laser material inside the box. And we have source of energy, electrical energy, a pump, which give electrical energy to the laser material, which make the laser material initiated or excited. When the laser materials or laser atoms excited, the electrons move to an orbit which further away from the atom. So now the atom is not stable. It's not stable because we have an electron in a further orbit. To gain stability again, the electron must go back to its original orbit. When it goes back to its original orbit, it releases energy which on photons. Photons, which means light. These photons inside the box keep going back and forth, till it reach adequate energy to pass through the partially transparent mirror, and then it's collimated and concentrated through this lens and have the laser light. We can say, according to the lasers, we can say we have wavelength and power. Wavelength, it's the distance between the peak of one wave or two waves. We have many types of lasers. We can classify the lasers according to the material inside the box. For example, if we have argon inside the box, we called it argon laser. If we have Diode inside the box, we can call it diode laser. If we have CO2, carbon dioxide inside the box, it could be carbon dioxide laser. We can also classify the lasers according to the wavelength. For example, diode lasers, we have 635, 810, 980s. For example, we have also blue lasers, 450. It can be classified according to wavelength, and it can be classified according to the status of the material inside the box. If we have gas material, it could be called gas lasers. If we have semiconductor material, it will called semiconductor laser. Today we will talk about diode lasers applications in peri-implantitis. Most papers talk about erbium YAG. Today I will talk about diode laser. According to the electromagnetic spectrums, lasers is not in the category of X-rays or cosmic rays. It's in visible and near infrared wavelengths. So it's not dangerous. So just we must take care of for the patient's eyes, the assistant eye, and the operator eyes. As we said, laser is light, so laser tissue interaction, same as light. We may have absorption, we may have scattering, we may have transmission and reflection. Diode lasers in history, we've started to use lasers in dentistry around 1989. In the first diode laser in the market, maybe in 1989. So it's semiconductor material, gallium, indium, and arsenide. Wavelength, the most famous wavelength, 810 and 980. Absorption of diode lasers, usually in pigments. That's why it's good hemostatic agent, because the blood is red in color, and to some extent in water, but a little bit. Dental use, we can use laser from 0.100 milliwatt to 2.5 watts. We have many devices, but we won't use more than 2 watts in any surgical procedures inside the mouth. Mode, we have two modes. We have either pulsating or continuous mode. Decontamination, we have two modes, as we said, decontamination or photobiomodulation mode, which is not surgical mode. We don't use that for cutting. And we have the cutting and coagulation property mode. Today we will talk about photobiomodulation. It's called soft lasers or cold lasers or low-level lasers or photobiostimulation. The general effect of our general mechanism of low-level laser therapy or photobiostimulation, absorption of the laser happens inside the mitochondria. The mitochondria is the organelle which is responsible for giving energy to the body, and it's the general mechanism that it's increase ATP and giving the body energy for healing. The clinical effects of low-level laser therapy are anti-inflammatory, analgesic, biostimulating, and bactericidal. Now we will start with the first case. 20 years old female patient, medically free patient, referred to us after having a fistula related to an implant since 9 months. This is how it looks at the first visit. If we see here, we can see the fistula area above to the upper left lateral. This is the area of the fistula. This is how it looks after 2 weeks of crown delivery, but it referred after 9 months. In 9 months, we've lost the keratinized mucosa, we've lost the supporting bone, and we have some recession, and it's changed from thick biotype to thin biotype. If we see here, it's the area of the fistula, and now there's no fistula because it's connected with the gingival sulcus. That's why the fistula disappeared. We can see the area of the fistula. First, I've took parallel periapical X-ray. If we notice here, we have poorly seated crown. And if we, from our first look, it looks like simple peri-implantitis case. Just we have vertical defect here and vertical defect here. But usually, or always, not usually, periapicals don't give us the real story. The real story is we don't have any bone, or only 1/3 of the implant just in bone. We've lost the buccal bone and we've lost the palatal bone. Just 1/3 of the implant inside the bone. If we notice here, we have an excess cement, which is the cause of peri-implantitis in this case. Again, this is how it looks on apical X-ray, and this is how it looks on CBCT, cone beam. If we notice here, we've not just lost the buccal bone, palatal bone, and we have lost interproximal bone mesially and distally. And almost now just 1/3 of the canine mesially in bone, and the lateral, the central, just half of it interproximal in bone. Again, if we have palatal view, we don't have any bone palatally on this implant surface, and we've lost the mesial and distal interproximal bone. So, in such a case, no one will think twice to extract this implant. But if we are going for extraction, we have one option, just one option, to do vertical bone augmentation, which is not that predictable. And usually we use autogenous bone, which means we will increase the morbidity after this surgery. And it's not predictable method, as I said, even though if I'm going for vertical bone augmentation, I don't have enough soft tissue or good biotype to cover that graft. So, even though if I am going for to restore this implant, not just I must have vertical bone augmentation, I must have good biotype after that. Why? I should have height of horizontal connective tissue or horizontal biotype, as we see from this file, 2 millimeters, and I must have vertical dimension of soft tissue 2 to 4 millimeters to have good amount of soft tissue to give an emergence profile to this case in the aesthetic zone. So I must have width of 2 millimeters and height of 2 up to 4 millimeters to have good emergence profile in the aesthetic zone. According to Salama et al. Classification, implants in the aesthetic zone, I must have papillas. To have papilla, as we noticed, we have lost the interproximal bone. To have papilla, I must have the distance from the bone crest interproximally and the contact point 4.5 millimeters, which in this case almost impossible to have it. So in this case, I decided to think outside the box and to try to preserve this implant and treat this implant in another way. So I tried to preserve this implant. I've started by use my plastic probe to measure the probing depth. It was 6 millimeters. And if we notice here, it's connected between the sulcus and the fistula. I've started with non-surgical treatment. I've used plastic sonic tips from Comet. And I've used plastic curates to clean the implant surface and the abutment surface. And I've used also titanium curates to clean the surface to prevent scratching the smooth part of the implant emergence. Again, I've used prophy units, and we can use prophy units from Action with glycine-based powder to prevent scratching the implant subgingivally. After 2 weeks, if we see we have resolution of inflammation, but we can see thinning of the gingiva at the area of the fistula, and we can see the shadow of the implant in this site. After 1 month, it ended up with this soft tissue fenestration. Here, I've took the decision to cover this fenestration with soft tissue graft, because my decision was to preserve this implant, because if I extracted this implant, I shall go for vertical bone augmentation. And if I didn't go for vertical bone augmentation, it will end up with a massive defect in the maxilla. So I've decided to do connective tissue graft around this implant. First, I must decontaminate the implant surface, which is exposed to the oral cavity. I've used prophy unit, I've used titanium brushes, and I've used minocycline with normal saline to decontaminate the implant surface chemically, and I used lasers to decontaminate the implant surface. After that, I've just did a single vertical incision, as you can see here, and 1 incision coronally, because I want to extend my connective tissue graft from here to the occlusal site of the implant, because I want to bury this implant and to cover it with connective tissue. Sorry, this is the palatal site. I've did single incision, and this is crisscross suture, and usually I cover the area which the donor site with platelet-rich fibrin. This is how it looks immediately after the surgery. After the surgery, always I use low-level laser therapy to enhance healing, to decrease morbidity, to decrease pain, and it increase angiogenesis to the area and enhance regeneration around the implants or bone graft. I've used it not just around implants. At any surgery in my clinics, I follow my procedure with low-level laser therapy. This is how it looks after 2 weeks. This is after, after 1 month. If we notice here, I've covered the fenestration, but unfortunately, I have lost the vertical dimension of the soft tissue. Again, this is how it looks after 3 months after maturation. Again, unfortunately, I've lost the vertical dimension of the soft tissue. So here I've decided to do another soft tissue graft to enhance the tissue vertically, to have vertical soft tissue augmentation, to have an aesthetic crown in the aesthetic zone. So if I've stopped my surgeries here, I will have a very tall crown in this side. So I've decided to do another connective tissue graft. Here it is, but unfortunately it failed. And now we have a vertical defect, vertical soft tissue defect, which is very difficult to treat. So the cause of the failure and suggestions. Most probably the cause of the failure of this graft is poor blood supply to this area, because it's over metal, not over bone or periosteum or connective tissue bed. So I think it failed because of lack of blood supply to my graft. Suggestions, I don't have any way to think just about pedicle grafts, which have its own blood supply. So I've decided to do pedicle graft from the palate with its own blood supply. Here is the design of the flap. I've moved up to here, and then I've deepithelialized this part of the graft and rotated it to the area to cover the implant and to enhance the thickness and change the biotype around the implant, buccolingually and vertically. This is how it looks immediately after the surgery. Again, after the second surgery, I've used low-level laser therapy, and after this one, I've used again low-level laser therapy. And this is how it looks immediately. And the donor site is filled with platelet-rich fibrin to decrease the morbidity at the donor site and to enhance hemostasis and regeneration from the donor site. This is how it looks after 2 weeks. If we notice, this is where the sutures, because I've inserted the graft, I epithelialized a part of the graft and inserted inside the buccal area. This is how it looks after maturation. I've gained vertical soft tissue. And again, now we are going to do a Maryland bridge, and we will not use that implant. We just kept the implant as a pin to restore the vertical dimension and to hold my soft tissue graft. This is how it looks after delivery. We have good gingival biotype, and even it's better than the other implant from the right side. And we have good height. This is how it looks after 2 years. This is before and this is after. So my message, don't rush to extract, try first. I've took a periapical parallel X-ray again, and I've noticed that I have before 3 threads covered, and after my work, I have just 1 thread covered. That means that we have regeneration. So when I've noticed that I have bone gain over this implant, and I didn't do any bone graft procedure around this implant, just soft tissue augmentation and low-level laser and laser decontamination, I've asked the patient to do CBCT. This is how it looks before. We have buccal bone 5.6 millimeters and palatal bone 6.3. After 2 years, we have gaining not just mesial distal as I've showed you on the periapical. On the buccal, now it's 6.6 millimeters. That means I've gained 1 millimeters bone buccally. And on the palatal side, it's 8.2. That means I've gained almost 2 millimeters palatally around this implant without any bone graft, just with non-surgical treatment for the implant and for connective tissue grafts and low-level laser therapy. Sorry. This is how it looks before, and this is how it looks after. If we notice, we have gained bone around the central. We have gained interproximal bone around the lateral distal to the implant. And not just that, we have this amount of bone buccally, which wasn't here. So I believe lasers help in bone regeneration, especially in peri-implantitis cases. Let's see another view. This is how it looks before palatally, and this is how it looks after. Here we can see almost every thread, just we have a little amount of bone here. But after 2 years, the whole implant almost covered by bone. Not just that. If we see interproximally, here we don't have any bone, mesial or distal. Now we have bone regeneration, mesial and distal. I've did merge for the 2 CBCTs before and after, so to give us where exactly we had bone regeneration. Every light blue color in this picture give us the area of bone regeneration. If we notice here, we have light blue regeneration interproximal. we have light blue on the buccal surface and on the distal surface. All the light blue are newly generated bone or regeneration. Just, I believe the cause of that is low-level laser therapy in the area. Now I will discuss another case, which I have published. If we see here, we have just only 1/3 of the implant in bone. Again, the first choice was extraction, but if I have extracted this implant, it will end up with a massive defect, not just a massive defect. We will lose the support around the 5 and around the 7. Let's see another photo. This is how it looks at CBCT. We don't have buccal bone or lingual bone, and we have almost just 1/3 of the implant in bone. This is parallel technique, just 1/3 of the implant inside bone. Again, I've just decided to try with this implant to preserve this implant. So this is passed from inside the pocket. We removed the ill-fitting crown, and again we did non-surgical treatment using Comet sonic tips, plastic, titanium curate, plastic curates, and again I've used Prophy and end that up with laser decontamination of the implant surface, followed by low-level laser therapy for this implant. This is the excess cement. We can see it on the titanium curate. And this is how it looks after 2 months. We can notice that we have some bone regeneration in this area. The first thing I think about, it's the power of the PDL for regeneration, because it started from the tooth or from the periodontal ligament of the tooth. But forward, we will change our mind. This is how it looks before, and this is how it looks after 1 year. We have almost complete coverage or complete regeneration without any gram of bone graft. I didn't use any bone graft in this case, just non-surgical treatment assisted with diode lasers and low-level laser therapy. If we see, it's not just mesial and distal. So I've changed my idea. The regeneration is not from the PDL, because we have bone regeneration lingually and buccally. It's not the periodontal ligament power for regeneration, because if it's the periodontal ligament, the source of regeneration, it will be just mesially and distally. But now we have regeneration around the implant, buccally and lingually. This is how it looks before. We have just 3 millimeters of the implant in bone mesially before, and now we have 8.5 millimeters. That means that we have 5.5 millimeters vertical bony gain. It's not just that we have circumferential bone regeneration around the implant. Usually when we have a horizontal defect around natural tooth, we are unable to regenerate such a defect with bone graft or with any other procedure. So what do you think around implant, which metal, and we don't have any periodontal ligament? So this usually horizontal defects is hopeless to regenerate, but in this case we've noticed that we regenerated this bone around the implant. On distal side, we have 4.2 millimeters before, and now we have 7.5 millimeters. That means that we have 3.3 millimeters gain of bone regeneration around this implant. I have published this case in the June 2021. Diode laser assisted horizontal bone defect regeneration and treatment of peri-implantitis. I think the title should be Circumferential Bone Defect Diode Laser Assisted Circumferential Bony Defect Regeneration in Treatment of Peri-Implantitis. And the first case will be published maybe in a few days. I don't believe in luck. We believe in hard work. And thank you very much for your attendance and for this kind invitation. And I'm ready for any question. Any questions?
Hello. So, Doc, do you hear me?
Yes.
What type of laser diode do you use?
I've used 810 and 980 wavelengths. And I've used low-level laser devices also. Most of devices support regular laser and low-level laser therapy. So I've used both.
So which is your favorite?
In these two cases, to be honest, I've used 810 nanometers wavelength for both, for regular laser and low-level laser therapy.
But so you think it will work even with 980 nanometers and also with low level?
I think it's the same concept. The regular laser we use to decontaminate, so it will be decontaminated either with 810 or 980. And most papers or most systematic reviews, there's not a significant difference between both wavelengths. For regeneration and low level, it's almost the same. But in these two cases and in the foot case, I've used 810 nanometers. But we have many wavelengths. For example, if we are treating a superficial ulcer, we can use, for example, 635 low-level laser therapy. But when we need for deep lesions like bony muscles, I think we should, some references goes with 810 and 980s to go deeper.
Yeah, I like it, and I use it a lot also myself. Other question, what's your favorite grafting material?
In these cases,
of peri-implantitis.
I didn't use any graft material in such cases, just regeneration. The own blood, the own body regenerate itself. But usually, it depends on the case and what I need from the case. Sometimes we use allogenics, sometimes xenogenics. It depends on the case.
So it's not it's case dependent on also on the soft tissue, I guess, because if you don't have enough soft tissue to support what you're doing, then you're gonna have some troubles.
For me, or for everyone, or scientific evidence based, the gold standard autogenous soft tissue graft.
Of course.
If we noticed the second surgery, it failed because I have very thin gingival graft from the palate. Plus, I don't have enough blood supply for the graft because it's over metal. So that's why I've changed my opinion and go for pedicle, free pedicle graft with the epithelium to have good thickness to cover vertically and horizontally. So
yeah, and also it has a very good blood supply because it's connected, you know.
Exactly, and always I'm going for autogenous in soft tissue grafting, either around teeth or around implants or ridge regeneration, as the case I've shared.
Yes, And I also liked the technique, and I also, you know, use kind of the same technique for cleaning too. Glycine is one of my favorite, and also the you know, the curettes, plastic curettes, sonic plastic curettes too. It's what I really like too.
There's no single protocol, I think, to decontaminate the implant surface. You can use everything. You have to decontaminate the implant. I've used also titanium brushes, if you noticed, with coolant. I used
I saw.
I've used minocycline with the saline to decontaminate it chemically. We've used physically, chemically, and with light. I've never, everything I have to decontaminate the implant, I've used.
That's really what we should go to.
And the glycine, it's amazing because we have special tips that you can do prophy inside the pocket. Even if you have 7 or 8 millimeters pocket,
yes,
you can use prophy with glycine powder in this area.
Yeah, it's true, you know. So I really liked what the presentation showed.
Thank you.
It was really nice to have you here with us. And
and hopefully I will soon, in a few days, we will publish our first case. The second one was published, and after that we are going for case series, because most of papers around peri-implantitis just on erbium YAG. On diode, there's not enough literature to take decisions, so I'm going for it. Now I will publish my second case report, and after that I have almost 3 to 4 cases to have a case series to publish to prove my idea in using diode lasers for peri-implantitis.
I like the idea, and as I told you, I use it. So it's something that it's really interesting and laser is
promising.
Of course the future. So it's something promising that we should also discuss later on to how it goes. So Doc, it was very nice to have you here with us this evening. I hope everybody learned a lot from your presentation, and good luck with the rest of your work and your life, and hope to see you again in the future.
Thank you.
Bye, everyone. Good night, friends.
Bye-bye.
And colleagues from all over the world.
Bye-bye.
Bye.